Frequency Podcast Network. Stories that matter, podcasts that resonate.
A nearly 30-year streak of Canada essentially being measles-free is over. We lost our measles elimination status, according to the Pan American Health Organization, about a year after cases started to spread. Now, the outbreak has infected more than 5,000 people in this country, including 2 infants infected in the womb who died after they were born. And restoring the status is possible, but it won't happen tomorrow. What does the status really mean? And how might our healthcare system be affected? I'm Kris McCusker, and in this episode of The Big Story, we speak to Dr. Barry Pakes, who holds many titles, including Program Director of the Public Health and Preventative Medicine Residency Program at the University of Toronto. Thanks for joining us. For people who don't know, what does this actually mean?
So measles elimination, so eradication would mean measles is gone from the whole planet. And there's only been one disease that's been totally eradicated, and that has been smallpox. So elimination is one step before that, which means that measles is completely not transmitting endemically, meaning there are no cases that are transmitted between people in any country. And in the case of elimination in Canada, obviously that's within Canada, but actually we've eliminated measles from all of the Americas, North, Central, and South America. And Canada's designation now as having failed the elimination test or lost the elimination status means that all of the Americas now no longer has the status of measles being eliminated. So it's a very significant change, and one that we sort of knew was coming more recently, but we are incredibly disappointed about and looking very much forward to reversing that.
Well, and I mean, that's the thing, right? It wasn't a surprise, but still quite disappointing. And Canada is able to get the designation back, but it will take time.
Yeah, it'll probably take a couple years. So what's needed to designate something as eliminated and what's needed to get it back is that you have to have no transmission of measles, meaning, in theory, you can have a couple cases imported from other countries and you can have a little bit of transmission between family members here and there. But when measles is eliminated, it means there isn't sort of ongoing transmission where you just have cases out of the blue popping up because there's transmission in the community. And frankly, since COVID, we sort of understand those concepts a little better. So no continuous transmission is one thing for 12 months, but we also need to have vaccination rates that are over 95% with 2 doses, which is going to be difficult because not only do we have to have that, and we're not that far away in Canada, but we need evidence of that. We need, good vaccine registries, which we do not have. We need a strong surveillance system, which fortunately we do have in Canada. And we need rapid response to outbreaks and capacity in local public health, which fortunately, again, we really do have. That's a real strong suit in Canada. But it's the continuous transmission that's the real challenge, and not only having high vaccination rates over 95%, but also demonstrating it. And that we have some work to do in Canada.
Well, and you're speaking to us today from a conference, and I assume this was discussed. You're surrounded by doctors and other officials that monitor these sorts of things. So what was the scuttlebutt, so to speak?
So I'm at the American Society of Tropical Medicine and Hygiene, which is in Toronto this year. It's about 5,000 people who mostly concern themselves with exotic, parasitic, viral, and bacterial diseases, not usually measles, because measles has been eliminated in most parts of the world and is fortunately something that has been less of a concern really for the past 40 or 50 years. It still kills 150 or 100,000 people, kids mostly, per year. So still a going concern. But the reason why it's not always top of the agenda here and at tropical medicine conferences or infectious disease conferences is because we know how to combat it. And the tool we have is very simple. All you need is to get vaccinated, ideally twice, and it is not a problem anymore. Nobody is going to die. Children are not going to die. We're not going to have to follow the transmission anymore. So it is something that's been mentioned a few times here, very unfortunately. And of course, the sort of bigger picture of why this is happening is relevant not only to measles, but to, combating all kinds of diseases, whether they're infectious diseases or non-infectious diseases. Overall, we're in a very different place right now than we have been in the recent past, certainly.
Yeah, and I mean, that's really my big question. Like, why did this happen? How did we get to um, this change in our status? What has gone wrong? Because as from where I'm sitting, as you just outlined, there's a simple solution to combat measles, A, and B, the MMR vaccine, as I understand it, and please correct me if I'm wrong, is one of the most effective vaccines out there. So how does this happen?
So in Canada, how this happens is a little bit happened rather is a little bit different than some of the concerns we have globally. So what actually happened here is that we had importation of a case in October of last year, and of course now that we're in November of this year, it's been a full 12 months of that particular ongoing transmission, and that's why we lost our immunization status. And it has spread in across 9 provinces and 1 territory. Not all from that particular case. There have been a very large number of cases in Ontario, outbreaks in Alberta and in Quebec that have been, both from that initial case that came in October of last year, but also a number of importations elsewhere. And really, the cases in this situation have been largely, and I can also speak mostly from the Ontario experience, have largely been in religious community, particularly in southwestern Ontario, that doesn't generally get vaccinated. And most of the cases in Ontario, at least, were restricted to that community. Now, the broader story, of course, is the much more concerning change in attitudes, very small change, but a significant enough change in attitudes towards vaccinations, whether it be to the measles, mumps, rubella vaccine, which, as you mentioned, incredibly effective, incredibly safe, not new or experimental or innovative at all, been around for many, many years, but also, of course, related to COVID vaccines and all of that. And so, more broadly, vaccine hesitancy, vaccine, questioning, and a lot of what's going on in the U.S. And globally in Europe as well, is that's the background story and what really we're most concerned about. In these smaller communities, there's going to be spread. It generally isn't going to spread beyond those communities. That's certainly the risk, and that's what we've been working incredibly hard to prevent by getting as many people as possible vaccinated. But the broader story is that we have somewhat decreasing vaccination rates, very marginally, to be honest. But with the MMR, with measles, we need 95% or more to really stop it, and we're below that, and we don't have a great vaccine record system. So even if people are vaccinated, we don't always have the best way of tracking that, certainly not in Ontario, but across Canada. And so those are some of the things that are very concerning, aside from, all of the other issues with disinformation and misinformation around science more generally, that is impacting, I think, not only, vaccine preventable diseases, but also health more generally. And that's something that we definitely talk a lot about in public health, in the area I work in, and in ethics as well, of course, incredibly concerning because of the ethical ramifications of all of this.
Well, and combating misinformation is not easy.
Definitely. I mean, it's become much harder, and in fact, we've just been talking quite extensively about that. And of course, at this conference that I'm at over this week, most of the people here are international, including a large group from the United States, and many of the folks here have incredible scientists who've done absolutely outstanding leaders in their field and outstanding work to save lives, and have lost their jobs as a result of the science that they do. And so, that is part of a very concerning narrative. Aside from that, to focus on Canada, we have our work to do here as well. But we're in that broader context of, what's going on globally. And, to mention also with respect to measles elimination, the UK lost their measles immunization elimination status in 2019. A number of other countries in Europe have lost it, since later in 2019, 2020, before the pandemic, and there are ongoing measles transmission in various parts of Europe as well. So there's many different elements to this. Much of it does revolve around vaccine misinformation and disinformation, but it has a slightly different flavor depending on where you are, depending on the local context.
Yeah, and the U.S. Not far behind us, likely to lose its measles elimination status, I think, in January.
Yes, there are a number of measles outbreaks in the United States. I believe in the high 40s in I think 30 or 40 states. Some states obviously more affected than others, but it hasn't been going on for as long. But they are certainly at risk of losing their elimination status. And what this really means, though, is aside from the infections and the disease and intensive care for children and deaths of children, because of course there have been several deaths in the United States, several in Canada as well from measles. It's a tremendous cost. All of this work that we are doing to follow measles and to fight disinformation and to make sure people are vaccinated is work that is distracting us from many other much more complex, very challenging issues we have in Canadian healthcare. And it's completely and utterly unnecessary. The deaths and the suffering and the disease is unnecessary, but also this extra work and the extra cost, millions upon millions of dollars to manage and follow these outbreaks just in Canada alone, let alone in the United States, when we have an incredibly effective preventive strategy. Very easy, takes seconds to get vaccinated for measles. And then, that's all you have to do. And then we can go on to managing all these other things like, the crisis in primary care, the crisis in emergency rooms, the wait time crisis, all kinds of other things in healthcare that frankly require our attention, and this should not.
That's really the larger question to all of this. Like, what is the impact on the healthcare system in general by losing this measles elimination status?
What it does mean is that people in public health have to work harder to try to get as many people vaccinated and to engage with the various registry systems we have across the country. In Ontario, we have something called the Immunization of School Pupils Act, where in order to attend school, you have to be vaccinated, and the vast majority of children in Ontario are. But following up on that takes a lot of work. What it also means is in a clinical scenario, and I work in clinical medicine as well and see patients, when you have a child, and every once in a while I've had these, and I've seen a case of measles myself, you have a child with a fever, under the age of 1, where you usually get vaccinated for measles around age 1 and age 4. And if they're under age 1 and they have a fever and they have a rash, before this year, I would say, that's just what we call a viral exanthem. It's just a cold. We don't need to worry about it. Just some fluids, some Tylenol, you'll be fine. But in a context in which we actually have to worry about something serious like measles, we need to send that child potentially for further investigations, or the parent needs to worry about that. And we need to do potentially, contact tracing there, or they need to make sure they stay away from others, or, think about who they're interacting with. It really changes the population level public health discussions, but it also changes some of the discussions right at the doctor-patient relationship, and some of the things that we need to do for our patients when living in a world where these diseases don't exist anymore. We don't need to worry about them, and we can worry about other things, or not worry about anything at all, which is really nice. And in a world where there is measles transmission, we have to think about it. We have to test for it. And again, I don't often test for measles, but in the past year, I've had to do that in kids under the age of 1 because, it was transmitting in the community and needed to test for it and stress out parents like that, which is really unpleasant.
It's funny because the TV show The Pit, there was actually a person that came into the emergency room on the TV show, and all these younger doctors were looking, oh, I don't know what that is. I don't know what that is. And then an older doctor came into the room and said, yeah, you're probably all too young to know, but that's classic measles. But it's something that, younger generations are not familiar with because it had, largely been eliminated. Only to sort of make this resurgence in the last couple of years.
Yeah, and it's not only measles. It's measles, it's mumps, it's rubella, and rubella causes all kinds of issues with pregnant women and their fetuses, deafness and fetal death, and that's going on as well. Things like whooping cough, pertussis, because of a lack of vaccination. Some of it related to just unable to get vaccinated during COVID, but whooping cough is out there again, and has made a comeback somewhat, and that can be really, really dangerous for babies too. There are a lot of advances in vaccination that resulted from COVID-19, and we're really excited to take advantage of those. There's an RSV vaccine now. There's all kinds of things in the pipeline that are going to be incredibly impactful. There's a shingles vaccine that's been around for quite some time now, but all of these innovations that they're for many of them, they're one and done, and you just get them and you don't have to worry about that thing anymore. And if only we were able to really get this message through to people, get the needles in arms, and most of them are needles, but not all of them, and then we can worry about these other things. It would be incredible, and that's really what we're working towards in public health and in clinical medicine. But there are certainly things that are complicating what we're trying to do. Some of them political, some of them, financial or systems related. But unfortunately, it's trickier than it needs to be.
Yeah. Just outline, if you could, like, who should be getting the MMR vaccine?
So anyone, babies should be getting the MMR vaccine when they at 12 months of age. When they turn one, thereabouts. Between, sometime after their first birthday. And generally, the Ontario schedule is at 4 to 6 years. Now, they could get it earlier, even at 18 months. As long as those two doses are separated by 4 weeks, those are considered two valid doses, and that's fine. In a situation prior to this year where we don't have measles circulating, we give, one dose at 12 months, and then we give one dose at 4 years, and that way, they're protected. And then you also have adults. Now, most adults, the vast majority of adults, are going to be protected from measles because of vaccination. And those born before 1970 will have had measles likely as children or as adults, whatever it would have been. And so they're protected. There are some people, an increasingly small group of people, actually like myself, who were born between, so 1970, 1995, or, depends on the province that you're in, who only have one dose, who could use a second dose in order to protect them. Now, each dose is well over 95% effective, but we give two doses just to be 100% sure. So, there's a small number of people that only have one dose that should get a second dose. But the vast majority of people who need to be getting vaccinated are children at the age of 1 year and 4 years. And for people who are at higher risk, and certainly over the past year, whether it was in southwestern Ontario or in York region where I was medical officer of health, or in various parts of Alberta, if you are at risk, then you, as an infant, then you can get that first dose a little bit earlier, or the second dose earlier, to make sure you're protected. But hopefully we won't need to be doing that. We can just give babies very simply, simple for parents, simple for clinicians, physicians, is to give it at those intervals, and then folks are protected.
And is this a free vaccine?
Yes, absolutely. It's part of the vaccine schedule in every province. Frankly, it's free pretty much everywhere on the entire planet. The only people it's not free for are for people who, frankly, are, and I do see many of these folks clinically who are coming from various other places in the world who've undoubtedly been vaccinated, but because they don't have their records with them and they want to work in healthcare, personal support workers or nurses or what have you, coming from other countries, they end up having to pay a couple bucks for the vaccine. But it is a provincially covered vaccine for anyone who's not fully vaccinated. It doesn't cost anything. Your family doctor, an urgent care clinic, a walk-in clinic, all of those sites should be able to give anyone the vaccine.
In your opinion, doctor, are there things that Canada could be doing that we're not doing to increase the vaccination rate?
Yes, so there's a number of things that we need to be doing, and when we say Canada can do, we have to recognize, of course, that healthcare is provincial. And so, what's going on in every province and what programs exist and how things are delivered, including public health services, are very different across the country. But one of the things that we have in common with almost every province, is that we have very poor vaccine record systems. So most countries, whether they be high-income countries or even low or middle-income countries, have electronic vaccination record systems. And we do not have one across Canada or even within most provinces that is basic in terms of its level of sophistication. And in a world that we're in now with a smartphone in every person's pocket and AI, poised to change our world, our vaccine record system still remains for the most part on these little yellow cards, and we've made some progress in various provinces, including in Ontario, where we have an electronic system, but it doesn't include everyone. And so one of the things the Pan American Health Organization, which is the American sort of version or branch of the World Health Organization that's responsible for this decision about measles elimination, one of the things they mentioned, and there were two main things. One was that Canada ought to implement an electronic vaccine record system countrywide. And if you Google it, you will find many Government of Canada documents around creating a national vaccine registry that we, over the past many decades, that we just simply haven't done, and we absolutely need to do. So there needs to be an investment in that. And the other thing they asked us to do, and frankly, everyone globally has to do this, is address vaccine hesitancy in certain communities. And, as I mentioned, there are particular religious communities in particularly southwestern Ontario, but across the province and in BC and in Quebec, Alberta, where this was mostly centered. We're more worried about vaccine hesitancy or vaccine refusal, and of course, the more extreme version of that, anti-vax sentiment in certain communities and on social media. And as the younger generations that are fluent in social media and get most of their news from social media get older and have children that need to get vaccinated, we need to have better strategies to make sure that all of them understand the science and don't fall victim to the anti-science rhetoric, because it's only them that is actually going to, them and their children, potentially they're going to suffer from it. So, those are the two big things: electronic vaccine record system and vaccine hesitancy. The electronic vaccine record system should be doable, really should be doable. Addressing vaccine hesitancy is, in some ways a very simple endeavor. It's just telling people the truth and communicating it in an empathic and effective way. But of course, it's nested within a very complex social dynamic that we're in right now. So that we have work to do, but we should be at least able to have that electronic vaccine record system. And hopefully this does spur action, not in the medium or long term, but immediate action, to get that record system going.
Well, and I mean, maybe you've sort of hit on the positive to come out of this change to the measles elimination status, in that, we should be doing better and we can do better. Do you think Canada gets its status back in short order?
I hope so. I think we are going to interrupt transmission, and the very large outbreak, 2,300 cases in Ontario, is over. The cases in Alberta are sort of dwindling. In Quebec, they're dwindling as well. So I think that's going to be doable. And as I mentioned, those two other elements, we have an incredible public health. Local public health system, of which I was fortunate and continue to be part of, and we have great surveillance. The trick is, getting from 92%, vaccine coverage to 95 to 100% vaccine coverage. That's going to be tricky. Now, I mentioned that the United States, or you mentioned as well, that the United States, was potentially, losing their status upcoming soon. The UK lost it a while ago. Venezuela lost it within the past 10 years, as did Brazil. But actually, in 2024, the Americas, the Pan American Health Organization, and all of Central and North America regained our continent-wide elimination status, because those countries got their elimination statuses back. It did take years, 4 or 5 years to get it back. I hope Canada will get it back sooner. We are in a non-enviable group of countries when we don't have measles elimination. And we want to get out of that as quickly as possible, not only for the health and well-being for all of us, but it's a stain on our reputation, on our good reputation. And it's unnecessary. We have a lot of other things in the health sector that we need to be attending to. And this is neither the most complex nor the most concerning. It just needs to get dealt with, and we can. It's simple. We can do it and move on to those other things.
Well, thank you so much for taking the time to talk to us today. And I really appreciate your insight and your advice.
Great. Thank you very much.
That was Dr. Barry Pakes, the Program Director of the Public Health and Preventative Medicine Residency Program at the University of Toronto. That wraps up this episode of The Big Story. We always welcome feedback. You can email us at hello@thebigstorypodcast.ca. I'm Kris McCusker. Thanks for listening.